Good morning and welcome to Grand Rounds. This morning we are happy to welcome Dr. Biljana Horn. Dr. Horn received her medical degree from the University of Zagreb, Croatia. She did her pediatric residency from Case Western Reserve University in Cleveland. She did her pediatric hematology oncology fellowship at the National Cancer Institute in Bethesda, and her pediatric neuro-oncology fellowship at the University of California, San Francisco. Dr. Horn is the Director of Pediatric Bone Marrow Transplant and Cell Therapy at the University of Florida. She will be speaking to us this morning on the hematopoietic progenitor stem cell transplant for pediatric malignant disorders. Please welcome Dr. Horn.
Thank you, and I'm delighted to be here. I'm new to Florida. I came from California just on July 1st, and a few days later I got an invitation from Nancy to come talk to you guys for the Grand Rounds, and I happily accepted, and this is my first time in Orlando outside of Disney World. So you guys really have a beautiful hospital, and I'll try to teach you today as much as I can in 1 hour about what I have done for the last 20 years. So it will be, some things will be really kind of a high-level view, and then we'll go in a little bit more details when we come to indications for transplant for pediatric malignancies. We'll hopefully have a few minutes for questions at the end. So basically, we will try to present the differences between allogeneic and autologous stem cell transplantation, and then describe how do we identify allogeneic donors for transplantation, and then we'll talk a bit more in detail about indications for transplant only for malignant disorders. So basically, allogeneic transplant is a procedure where hematopoietic stem cells, and we usually call them briefly stem cells, from one of the 3 stem cell sources, and those sources are umbilical cord blood, bone marrow, or peripheral blood, from one person are infused into another person. And for the transplant to be successful, the recipient has to be immunocompetent, because if you have an immunocompetent recipient, even if the transplant is completely matched, rejection will occur. And we'll talk a bit more why that happens. Autologous transplant is really not an immunologic procedure. It is a procedure in which one's own stem cells are stored and used later on in order to circumvent the toxicities of chemotherapy. So basically, it allows you to use much more chemotherapy than you would without those stem cell infusion or stem cell rescue. And that is important for 2 reasons. One is that cancer cells develop resistance to standard dose of chemotherapy, so you need much more. And then another reason is in brain tumor patients, there is a blood-brain barrier. So you need much higher peaks of chemotherapy in order to reach that area, and that higher peak is sufficient to erase your bone marrow, so it cannot really be used without support from the stem cells. So when is a stem cell transplant indicated in general? So it is indicated when there are no alternative therapies, or when the outcomes with alternative therapies are significantly inferior to outcomes with transplant. And that what is significantly inferior really, sometimes is not completely objective. Some people would say 10 to 15% survival advantage over other available therapies. Other people, would require even higher. Transplant is related for long-term effects such as graft versus host disease and infertility, and often hormonal deficits and growth disturbances. That is why we want to see that survival, overall survival, will be significantly higher. Because even though you survive, the quality of life may not be the same as it would have been if you have not undergone that procedure. So a bit about those 3 stem cell sources. The oldest stem cell source is a bone marrow, which we consider still to be the standard source in pediatric transplant, in particular for non-malignant disorders. Peripheral blood stem cells are used more increasingly, particularly in adults, and that is a source where we mobilize stem cells. We give patient a drug, usually G-CSF, that moves stem cells from the bone marrow into peripheral blood, and then just filter peripheral blood, do apheresis procedure, and collect the product that is rich in stem cells. The differences between bone marrow and peripheral blood is that with peripheral blood, we can usually get more stem cells, larger quantity, but we also get more T cells, and the risk of graft versus host disease, in particular chronic graft versus host disease, is higher when peripheral blood stem cells are used. Now, chronic graft versus host disease sometimes can be of benefit to patients with cancer because it can provide some cancer control. However, in children, in particular children with non-malignant disorder, chronic graft versus host disease or any graft versus host disease is really not beneficial. It affects it adds additional morbidity and sometimes mortality as well. Now, cord blood can be also used instead of bone marrow and peripheral blood stem cells, and I'm sure that you all remember about 10 years ago, cord blood came into use, 10, 15 years ago, and it was very fashionable. We were trying to do cord blood for everything. The advantages of cord bloods are that you could cross HLA barrier a bit better. So basically, these are less differentiated cells, so they allowed for higher HLA mismatch when they're used. But the main disadvantage of cord blood is the limited quantity of stem cells. On average, you get only 10% of stem cells that you would have obtained from bone marrow or peripheral blood, and that often led into failure of engraftment and delayed engraftment, so that those are the biggest disadvantages of cord blood, and we are now in a phase of, cord blood transplants are going down, and I'll show some pictures about that. Now, what is conditioning regimen? So basically, before we infuse the stem cells, and stem cells are infused just like a platelet or blood transfusion. They go through your IV, and they infuse, and they go into the bone marrow, finds their place, and starts growing there. But before we infuse the stem cells, we have to condition the recipient. And conditioning means just providing a high-dose chemotherapy. And sometimes, for some conditions such as acute lymphoblastic leukemia, we also use radiation therapy. And the goal of conditioning is to eliminate residual immune cells and make some space in the bone marrow for the new cells to grow. And that space is required because there's a competition in the stem cells, the recipient and the ones that you infused. Now, if we are doing a transplant for cancer, then additional benefit of conditioning is that it should eliminate any residual cancer cells. We ideally like to get the patients in as good remission as we can when we are transplanting for cancer, but we never really know that someone has no residual cancer, so conditioning is usually for cancer patients selected so that it has activity against the underlying disease. And the choice of conditioning, as I said, will depend on indication for transplant, and we talk about more myeloablative conditioning as opposed to immunoablative conditioning. Let's say you have a patient with severe aplastic anemia with what we call an empty bone marrow. We really just need to immunoablate, eliminate any residual lymphocytes and immune cells that may present obstacle to engraftment. So in that situation, we can go and select purely immunoablative regimen. For most other conditions, we will combine myelo and immunoablation. Myelo meaning you're trying to eliminate the stem cells and the myeloid lineage. Immuno is basically lymphocytes, lymphocytic lineage. So basically, we will look at, based on what is the goal, what is the underlying disease, and decide what kind of regimen we want to choose for the patient. So how do we find a donor for allogeneic transplant? So these are type of transplants based on HLA matching. Syngeneic transplant is identical twin transplant, and immunologically that acts as autologous transplant. So you can use a twin transplant, but let's say if you have a twin and matched sibling and patient with leukemia, you will basically try to use a matched sibling over identical twin if you have leukemia patient, because you want to add some of the graft versus leukemia effect, which is going to be better in a situation of slight mismatch. So basically, if you have a disorder, let's say you have some genetic disorder with identical twins, that's kind of very unlikely because they might inherit, genetic disorder. But if you did have non-malignancy and one twin had it, another didn't, then yes, you could go ahead and use that identical twin. So fully HLA-matched related transplants is your standard matched sibling transplant. That is probably the one of the oldest types of transplants. What we call a gold standard for transplant. Outcomes are usually the best if you have a matched related sibling. If you don't have a matched related sibling, then we would do a donor search and try to identify as well as possible matched unrelated donor transplants. And we will be doing HLA typing the recipient and putting that type in the computer, and the computerized database will provide us a list of potential voluntary donors who signed up anywhere in the world willing to donate. And then we will approach the donor center and try to identify those people. They will send a blood which will be retyped, and we will basically identify a donor. So when we start looking for a donor and we tell you, oh, it's going to take us 3 months, it's literally because, we have to, this computer search is 2 minutes. It doesn't take long. But then you have to go to those centers, find those people. Sometimes people sign up, they move, they don't leave their forwarding address. You need to negotiate time that they can come to donor centers, donate that blood shipped, comes to your HLA lab, and then you start typing it. So it does take time to find the donor. When we look for those unrelated donors, we usually try to identify several up front, because we know that by the time you select the donor and then they have to go through the physical and negotiate the times, you may need more than one donor to be able to bring one of them to process of donation. But as much as it seems complicated, it works amazingly, and we know which donor centers work faster than others, so we kind of go target those centers usually when we're looking for a donor. Now, if you don't have this very well matched or well-matched unrelated donor, we can also do a mismatched related transplant, which is also known as haploidentical transplant. And that is done usually from one of the parents in pediatric situation, or one of the siblings who are not fully matched but who are half matched. Since this type of transplant has been done for years using a procedure called T-cell depletion. So basically in vitro depleting T cells and infusing transplants. And most recently, over the last 5 or 10 years, we are increasingly using procedure of in vivo depleting haploidentical donors by giving a high-dose cyclophosphamide post-transplant. And those in vivo depleted actually seem to be working much better, less complicated, and it's kind of lower tech procedure, and can be done pretty much at any transplant center. And finally, the last cell source that we can use would be mismatched unrelated transplants or mismatched cord bloods. Now, some centers would not have these identical orders. I think that when it comes to number 1, 2, and 3 of order of selecting, there's a little controversy. However, when you get to this point 4 and 5, some centers prefer T-cell depletion, some centers would prefer cord blood transplant. So it really depends on your experience. We know that when you do a lot of certain type of transplants, you get better at it and you get a better outcome. So again, there's no one order fits all transplant centers. So how do we look for HLA-matched donors? So basically, HLA genes reside on the short arm of chromosome 6, and they encode for surface antigen-presenting proteins, and those proteins encode certain genes, also known as antigens, which play an important role in defense against infection, recognition of cancer, and autoimmune disorders. So there are a number of genes there that belong in this HLA category. We currently type for A, B, C, and DRB1 genes. This is a minimum number of genes that is recommended by National Marrow Donor Program to be typed. We frequently type for 2 other genes, DQB1, and we also type for DP. So when we want to do extensive typing, we will do this typing at 12 loci. So as I already discussed, donors done through National Marrow Donor Search. Again, typing is done at 8 at a minimum, but all the way up to 12 antigens. Process takes 6 to 12 weeks, so a bit longer. And we already discussed this order, not only of HLA-match, but also stem cell source. Once again, for pediatrics, we prefer bone marrow over peripheral blood stem cells over cord blood. In adults, very often they would flip this and use PBSCs over bone marrow, because again, in adult donors in particular, especially older donors, they may have more difficulties collecting a bone marrow. There are some other issues that are important in donor selection, such as the CMV status. We try to match for CMV status. So as you know, CMV is one of the herpes viruses. There are a number of those. And once when you have had a CMV, it stays in your body for the rest of your life. So every time your immunity goes significantly down, CMV load can increase. So it is very common for CMV to increase, the load to increase during the transplant. And if the patient does not have immunity or cannot develop immunity against CMV, that reactivation, which is just documentation of higher load in the blood, can turn into disease. And CMV disease could be something like CMV pneumonia, encephalitis, hepatitis. Once when you get the CMV disease, historically those patients would have a 50% mortality rate. Now, nowadays we do screening for CMV weekly while you're in a transplant. We have some medications, but the very important part that we do is try to match for CMV status, meaning if the recipient is CMV negative, we would try to match for and find CMV negative donor. Now, majority of population, depending where you live, is CMV positive. Anywhere between 50 and 85% of population is CMV positive. So if you cannot find a CMV negative donor for CMV negative patients, that is actually not that big of a deal. It is a bigger deal if you have a CMV positive patient and you provide CMV negative stem cells, because then you don't provide any CMV immunity. So basically, if you CMV positive cells in a negative patient, that patient may get infection and reactivation. However, donor cells will also bring some immunity against CMV, and it will be easier treating that patient. But if you provide CMV negative cells and the recipient is CMV positive, then those donor cells, while the patient is on other immunosuppressive agents for suppression of graft-versus-host disease, will not be able to build adequate immunity. So we always try to match for CMV. Now, we are lucky nowadays that there are third party and donor-specific CMV cells. So we basically, if we have a situation where CMV is a big issue, we can try to identify, still on a research basis, cells that are immune against, they basically CAR T cells against CMV, infuse them in the recipient, and eliminate CMV in that way. And we kind of use this for difficult cases where there is no CMV immunity. We also try to do gender match. We know that if a female is selected as a stem cell donor, in particular females with multiple pregnancies, there is a higher risk of graft-versus-host disease. When it comes to donor age, typically younger is better, except in pediatric population. In pediatric population, we always choose the oldest available donor. Sometimes we would choose the donor who is the closest match to the age of the recipient, pediatric, or maybe donor who has the best psychological relationships with the recipient, because we need to take in account also in pediatric situation, child's willingness and motivation to donate for the sibling. So if we have a multiple matched sibling donors, we actually would like, our psychologists, social workers would usually help us in a donor selection, but we try to go for a donor who actually wants to donate. And it's really quite common to have someone in the family, goes forward and says, I want to donate for my sibling. So I don't think it's as much of a problem as, sometimes people, high up who don't deal with those patients, believe it is. We are not coercing children in donation. It's usually opposite. Usually they volunteer and they really want to do that. And then ABO incompatibility is not a barrier for transplant. It's just if we do have ABO incompatible stem cell product, we have to remove the red blood cells before we infuse that stem cell product. Just that procedure might reduce some of your cell counts that you have, so you have to kind of have a bit more of a product than if you have an ABO compatible product. So just a little bit about the general trends in transplant. These slides are actually coming from an organization called Center for International Bone Marrow Transplant Research. All transplant centers are obliged to report the data. So we know that U.S. centers all report. There are audits to these reports, so those data are very accurate. So this is the most updated data for transplants. As you can see, in 2015, allogeneic transplantation, that is the green line, the total number of allogeneic transplantations is about 8,000, and that number seemed to be pretty steady for the last 3 years. And when it comes to autologous transplant, there are more autologous transplants than allogeneic, so the number is about close to 14,000. When it comes to allogeneic stem cell transplant donor types, you can see that unrelated donor bone marrow peripheral blood, which is the orange line, is the most common type of transplant. And then the second one, the dark blue one, is identical sibling. And you will see there at the bottom two other types of transplant. This green one, other relative, that is increasing, that is haploidentical related transplant that I was talking about, that we are now, these transplants with post-transplant cyclophosphamide are on an increase. And the one that is on decline is unrelated donor umbilical cord blood transplant, that light blue. So when we look at basically matched sibling donor transplants in pediatric population, patients less than 18 years of age, you will see that the bone marrow is predominant stem cell source, as we said, in pediatric patients. When we look at unrelated donor transplants in pediatric patients, again, bone marrow is predominant, but then we have a fair number of cord blood and peripheral blood transplants. And that, I guess, that completes this part. So we are moving to the second part of our talk, which is indications for transplant. Again, we have first indications from the registry for all transplants in the United States. And the reason why there are most of those autologous transplants is because adult hematologists and oncologists use this procedure a lot for probably their most common disorder, which is multiple myeloma. So that the first tall green bar that you can see is basically majority of transplant for multiple myeloma, followed by non-Hodgkin's lymphoma. Again, those are all adults. The most common indication for allogeneic transplant, outlined in blue, is acute myelogenous leukemia. That is, again, predominantly adult, because that is not the most common type of leukemia in pediatrics. Acute lymphoblastic leukemia is more common transplant indication in pediatric population. Now, other cancers, as you can see down there in green, those pediatric autologous transplantation for, let's say, neuroblastoma or brain tumors would be in that category. But overall, when we look at all transplants, there are many more transplants than in adults than in pediatrics, and then multiple myeloma is the most common indication for autologous, and then AML for allogeneic. Now, when we talk about pediatric stem cell transplant, I already mentioned that when we use a transplant for cancer, the goals of transplant are to reduce tumor burden, then to restore marrow function after marrow ablation, that is in autologous transplant, and then graft versus leukemia effect in allogeneic transplant. So basically, immunologic difference between donor and recipient are very important for treatment of leukemia, because that is something that can persist over time for years. It is easier for infused, slightly immunologically different bone marrow or stem cells or immune system to recognize the recipient's tumor. We know that graft versus leukemia effect exists even if you do not have a graft versus host disease, but it exists also when you do have a graft versus host disease. And how do we know that? We know that from all the studies where they basically looked at children getting, or anyone getting transplant from identical twins, from met siblings without graft versus host disease, and then met siblings with graft versus host disease. And the relapses were the highest if you get a transplant from a twin, followed by transplant from met sibling without graft versus host disease, and then from met sibling with the graft versus host disease. In a group of disorders known as the marrow stem cell defects, so immune deficiencies, so that would be something like Fanconi's anemia, or that would be severe combined immune deficiency, or Wiskott-Aldrich syndrome, or any other immune deficiency. The goal of transplantation is to replace defective cells or defective immune system with a healthy one. And obviously, you need to have allogeneic transplant. Now, for more and more immune disorders, people are now using autologous transplant with the gene therapy in order to basically correct some of the genetic defects. But those are investigational until we have a specific gene therapy for every genetic disorder. Allogeneic stem cell transplant is still standard of care for those patients who would have otherwise died if their underlying defect was not corrected. Then we do provide the transplant for some of the inborn error of metabolism. Sometimes we don't quite understand how does transplant work in those conditions. Let's say a disorder such as Hurler's disease, where there's a defective enzyme. We know that enzyme is produced in hematopoietic stem cells, in particular in monocytes, and then we provide this ongoing enzyme in the blood circulation. Some of the enzyme can diffuse into tissues, but typically if you are replacing something with the enzyme that's not in every cell in the body, you don't get a full correction. So if we were to transplant patients with Hurler's disease, we will correct some manifestations of disease, but not all manifestations. And then a transplant has been used in autoimmune disorders. There was maybe some 20 years ago a big movement to using transplant in autoimmune disorders. However, parallel to a use of transplant, a number of new medications, immunomodulatory medications have been discovered, so we kind of backed off. So basically the idea of using transplant in autoimmune disorder is to reset the immune system. And that can be done easily with just a very high dose cyclophosphamide, even without really using any infused stem cells, or completely, replacing a transplant immune system. Now, if the autoimmune disorder is based on some defect in the immune system, then obviously we treat this category of disorders as we would treat immune deficiency. So we are moving now to the last portion of our talk, which is just going over indications for transplant for pediatric malignant disorders. Now, I will just say that those indications and the risk classifications change all the time. So every time you get a patient referred, you have to kind of go to basis, make sure that the patient is still eligible and that there are no any new treatments that might be actually more promising than transplant. So basically, again, what you hear today probably will not be valid in a year or two, and I try to go over this list and understand what is still valid, what is not. As I said, acute myelogenous leukemia and acute lymphoblastic leukemia are the two most common disorders that we transplant when it comes to malignant disorders. Basically, current understanding of patients who may benefit from transplant. And I base these slides usually on what the COG outlines in their protocols, because Children's Oncology Group, which is a group that designs protocols and provide some general guidelines for the treatment of oncology patients, is followed throughout the country. So I think once when COG puts something in their study, it becomes more of a standard of care. So I try to follow those, although obviously there is a variation, and these indications are never absolute. So we currently offer transplant to high-risk AML patients in first remission, and those high risk is currently defined as FLT3 ITD with allelic ratio. I'm sorry about that N. The computer likes to add that N whenever possible, of more than 0.4. And again, that indication is, in my opinion, somewhat soft, because there is a number of new drugs that are being approved. And, like I think one was approved just last month, that are specifically targeting this genetic mutation that historically has been linked with a higher risk of relapse. So again, if you, there are drugs that potentially may reverse and make this disease not at high risk. The same as we used to, believe that BCR-ABL in acute lymphoblastic leukemia is super high risk, until we've gotten a drug that can really target that mutation. But currently, again, most of those patients on the COG studies, if they do have an available donor, will proceed to transplant in first remission. Then there are some other genetic malformations, such as monosomy 7 or 5, or deletion of chromosome, a short arm of long arm of chromosome 5, without favorable cytogenetics. Those are currently eligible for the transplant. Then patients without favorable cytogenetics and with minimal residual disease, more than 0.1% at the end of induction 1. And then patients with relapsed or progressive bone marrow or extramedullary disease at any time. So basically that would be, so anyone with AML who has relapsed previously or progressed on treatment would be a transplant candidate. The condition offering for patients with acute myelogenous leukemia is busulfan fludarabine, with or without serotherapy. When we say serotherapy, we mean rabbit ATG or horse ATG, so basically drugs that we use in order to additionally immunosuppress the recipient and immunodeplete infused cells to reduce chronic graft-versus-host disease most of the time. So basically we use busulfan fludarabine, and then graft-versus-host disease prophylaxis, which is given in every allogeneic transplant, consists of tacrolimus and methotrexate. These are some of the outcomes for AML in first remission from the most recent large COG study. This is AAML, which occurred 1,000 patients, close to 1,000 patients, and closed in 2010. And the outcomes for the transplant in first remission, and in this study only patients with matched family donors went to transplant with first remission if they had intermediate risk disease. Outcomes with transplant was 60 to 75%, with the relapse rates of 24 to 38%. Again, this study has had two goals. One was to study transplant, another one was to study response to this monoclonal antibody called gemtuzumab. And obviously this monoclonal antibody was very effective and improved survival. However, subsequently this antibody was taken off market so no one could use it, although the outcomes are better, and actually has been returned back to market once again now. So this is an option to some patients with acute myelogenous leukemia currently. Now, this is just to explain to you how the CIBMTR classifies risks, so that you can understand the survival curves that I will provide for you on the subsequent slides. So basically, patients who are with AML, ALL, or CML are classified as early phase if they're in a first complete remission or first chronic phase, intermediate phase if they're second or subsequent complete remission, or chronic phase or accelerated phase, and then advanced phase if they're basically not in remission. So these are outcomes of all pediatric patients who have received a transplant for acute myelogenous leukemia in this fairly large time period, so 10-year time period for the whole United States. And as you can see, there is not that much difference in survival if they received the transplant in an early phase or intermediate, so basically first or second remission, because patients who are allowed to go to transplant in a first remission are usually higher risk patients just by nature. And those with advanced disease, meaning those who could not come to transplant in a reasonable remission, have significantly lower outcomes. So outcomes currently for sibling donor for acute myelogenous leukemia are in about long-term outcomes in about 60%, and for those again without good disease control can be as low as 20%. So this is unrelated donor transplants. Now this includes adults as well, because there are no specific data for pediatric population for unrelated donor transplants. And as you can see, this early and intermediate phase really don't apply very well to acute myelogenous leukemia. There's almost no distinction between the two. So what are some other myeloid disorders that are eligible for transplant? So myelodysplastic syndrome is one of them, and myelodysplastic syndrome is defined as the presence of two or more of the following, which include sustained cytopenias, dysplasia in two cell lines, clonal cytogenetic abnormalities, in particular of chromosome 7, and then that is also blasts in the bone marrow have to be less than 20%, because if we have more than 20% blasts, then they would be in the acute myelogenous leukemia category. So all the studies, COG studies, used to enroll patients with myelodysplastic syndrome to acute myelogenous leukemia studies as well, and those patients did not have good outcomes. Basically, currently, the recommendations are that the patients with the myelodysplastic syndrome proceed to transplant, again, without necessarily getting prior chemotherapy. Often, if they do have some blasts, we would probably recommend one dose of chemotherapy and then try to eliminate those blasts and proceed to transplant. Some other myeloid disorders that we commonly transplant are treatment-related acute myelogenous leukemia and treatment-related myelodysplastic syndrome. And those are actually getting to be more and more common as more patients are successfully treated up front. It is not uncommon for us to have a patient with acute lymphoblastic leukemia who 2 or 3 years after successful treatment for acute lymphoblastic leukemia comes with myelodysplastic syndrome. So not a relapse of same leukemia, but myelodysplastic syndrome. Also, we see a lot of those after treatment for Ewing sarcoma, some after treatment for osteogenic sarcoma. So basically those, again, with the survival of patients with upfront, children with upfront cancer, we're seeing more and more treatment-related myeloid disorders. So when we talk about treatment-related disorders, we sometimes categorize those in alkylating agent-related. Those occur a bit later after treatment, and then topoisomerase inhibitor-related secondary AML and MDS, which usually have a shorter latency. Those treatment-related MDS and AML patients may be a bit more refractory to therapy than the novo MDS and AML. That's historically has been like that. We do approach those as usually myeloid malignancies, and I have transplanted a number of those patients successfully with a good long-term outcome. Another disorder that at this point still requires a transplant, and transplant may be the only curative therapy, is juvenile myelomonocytic leukemia. They again are treated, depending how they present, they either do get some chemotherapy up front or proceed directly to transplant. And these are some of the older outcomes of patients with myelodysplastic syndrome based on the donor type on the top, or based on myelodysplastic syndrome classified by kind of older adult classification. And this is survival for all patients with myelodysplastic syndrome from CIBMTR. Again, unfortunately, there is no pediatric-specific data. Many more adults with myelodysplastic. There are many more adults with myelodysplastic syndrome than pediatric patients. Chronic myelogenous leukemia used to be a common indication for transplant in adults and occasionally pediatric, because this is not a common pediatric disorder. However, since the introduction of tyrosine kinase inhibitors, and the first of them was imatinib or Gleevec, transplant has become the second-line therapy for those disorders. And we are using transplant now only for treatment failure, or when there is a documented tyrosine kinase inhibitor resistance, or for patients who present, I would say, probably in a blast crisis phase. So some people say started phase as well. Conditioning for chronic myelogenous leukemia is similar to acute myelogenous leukemia conditioning, and we would typically use busulfan fludarabine for those patients. Now, moving on to acute lymphoblastic leukemia, which is the most common leukemia that we transplant. So indications depend on whether a patient has a B-cell leukemia or T-cell leukemia. For the B-cell ALL, patient is transplanted in either first or second remission if there is a positive minimal residual disease, more than 0.01%, at the end of consolidation. So that is an indication, basically prolongedly positive minimal residual disease is indication at any time. In a second remission, for patients who relapse, it will depend whether they relapsed after starting as a standard risk ALL or after starting as a high risk ALL. We recommend that any patient who was originally classified as a high risk undergoes a transplant in a second remission. In the case of relapse, there is some controversy. Some people are still trying to not transplant late relapser, even though they started as a high risk. And I'll show you what I mean by late relapser. So basically, in CR2, we recommend transplant if they relapse less than 36 months from diagnosis for patients who originally started with standard risk disease, which is majority of patients, or those who had the early extramedullary relapse, which is defined as less than 18 months from diagnosis. So hypodiploid leukemia is still indication for transplant in first remission, although there is controversy about that as well, as there is a very small study from St. Jude's showing that if those patients achieve a good clearance of their disease up front, that they actually don't require transplant. Some patients with T-cell leukemia, known as early T-cell precursor leukemia, can respond slower to therapy, and disease may persist for several cycles of chemotherapy. They may not necessarily, require transplant, and we don't use this at the end of consolidation rule for them because, again, they're a different type of leukemia. Sometimes we will transplant patients, in particular if they have a matched sibling donor, if they just cannot tolerate standard chemotherapy. Sometimes that chemotherapy can be complicated quite a bit, and then patients are missing so much chemotherapy that oncologists are concerned about their ability to deliver and keep them in remission, in which case some reduced toxicity transplantation can be done. So these are the slides, and to your left you will see the one that distinguishes the patients who have a presence of minimal residual disease at the end of consolidation by the amount of minimal residual disease. So basically, if patients have a MRD at the end of consolidation, you can see that this long-term survival, like that 6-year survival, you'll see that the curve never really stops dropping down, that even at the 6 years, there are some relapses. So that is the group of patients that actually, as soon as we identify that they had a positive disease at the end of consolidation, we move them to transplant. And in this study, they actually even allowed them to change the treatment after seeing this positive residual disease, and they still did not do good with the chemotherapy. This is a study on which we base those recommendations about the time to relapse as early relapse and late relapse. And it's a bit more complicated slide, but if you can look at on the left side outcomes, you will see, actually on your right side, you will see outcomes as leukemia recurrence, and then treatment failure and overall mortality. So in patients who relapsed with less than 36 months from diagnosis, if you treated them with chemotherapy, the relative risk of leukemia coming back would be assigned as 1. That relative risk was significantly lower, 0.49, meaning that there was less recurrence if they were treated with a TBI conditioning regimen if they received a transplant. However, for patients receiving non-TBI conditioning regimen, the relative risk was actually higher. So again, when you look at treatment failure, risk of treatment failure decreased in those who received TBI regimen transplant, and overall mortality was down. In patients with a late relapse, you can see that that difference was not significant. So they did not have this advantage of transplants. So this is basically a study on the basis of which we make recommendations that patients who relapse past 36 months post-transplant can go and be reinduced and get a chemotherapy. Again, this whole slide has been done, and the whole study was done on the patients who started as a standard risk. That is why when I present this data, I kind of emphasize that this is in the patients who were treated as a standard risk up front. This is just a bit slide talking about conditioning regimens. Although TBI is still standard of care, there's a lot of data coming out from Europe documenting that TBI actually can be avoided successfully, even in children with acute lymphoblastic leukemia. But basically, this slide is showing that historically in treatments done here in the United States, patients who do get total body radiation in a range of 12 to 1300 centigrade, with 1 or 2 other treatments do a bit better than patients who get more than 1300 or 1300 centigrade total body radiation with 2 drugs. So you basically, there's a limit to when adding more is beneficial. That's the point of this slide. The most heavier treated or conditioned patients with this group 4, and they had the worst outcome, while the other groups who received total body radiation kind of clustered in the middle. Just a bit about the current trends in transplant. A lot of new events have occurred over the last 3 or 4 years in acute lymphoblastic leukemia. So what is our current understanding of treatment in acute lymphoblastic leukemia? So basically, matched sibling donor and matched unrelated donor transplants have equivalent outcomes. There's no reason to make any stratification as we used to have in the old study. Oh, if you have a matched sibling, you do this. If you don't have a matched sibling, you do this. So basically, if you have a matched sibling or fully matched unrelated donor, the transplant outcomes are identical. Then non-TBI regimens are actually using increasingly. In Europe, they're lucky to have this drug treosulfan. In the United States, treosulfan is not approved, so we're still using busulfan-based regimens. Again, the old studies showing inferior outcomes of patients receiving non-TBI regimens was probably was biased by selection of those patients. It was retrospective studies. Basically, doctors assigned worse patients to, chemotherapy arm, and then they didn't do as good as TBI arms. So we definitely need a prospective studies looking into non-TBI regimens. Total body radiation giving it to a child 1200 centigrade is just not a good thing, because it does affect basically growth. It affects hormones. It has neurocognitive impact, and no one really should like or insist on providing that treatment. Now, what is also has entered into practice, and there is not really entered into practice because we still can't do next generation sequencing for every patient, but basically next generation sequencing minimal residual disease, if it can be followed, it can predict relapse much earlier than our multi-flow cytometry that we are still currently using as a standard of care. So with the genomic sequencing, identifying genomic profile for each individual patient, we do have ability to follow the minimal residual disease much better than we ever did with the cytoflow. Now, there is a new monoclonal antibody called blinatumomab, which has been introduced for patients mainly to get them to remission. It is a good drug because it's another way of getting patients into remission, in particular patients who are resistant to all other treatments. This is anti-CD19 monoclonal antibody. Unfortunately, durations are very brief. You have to achieve your remission and then you have to move them to transplant. We literally would have a patient who starts with 70% blasts, gets a first round of blinatumomab and gets to 0, and you start infusing second round by looking for donor and MRD comes back. So it's not a long-term solution. It's really one cycle at most, get them to transplant. It has not replaced a transplant in any way. As you probably all have heard, because it has been a big hype throughout the papers, CAR T cells basically have been approved. They're not really free to use. There are a lot of obstacles still to using them, but basically they are used for relapsed refractory B-cell ALL before or after transplant. They have not replaced the transplant. We are still trying to learn in which instances this may be the last curative therapy and in which instances one needs to follow that with other treatments. I have certainly transplanted patients who have gotten CAR T cells before the transplant and have certainly sent the patients who relapsed after transplant for CAR T cells. So they're used before or after transplant, not instead. And this is just the outcomes of patients with acute lymphoblastic leukemia, less than 18 years of age, based on a disease status. Here we have a bit more distinction between early and intermediate disease. And this is unrelated donor stem cells for ALL. As I was saying, very similar curves for related and unrelated donors. A little bit about solid malignancies. Neuroblastoma is the most common solid tumor in pediatric patients, other than brain tumors that we transplant. Only patients with a high-risk neuroblastoma require transplant. And the most recent data from COG ANBL 0532 study indicated that 3-year event-free survival for children with neuroblastoma is 63 for tandem transplants, meaning 2 transplants, and 48 for single transplant. And that difference was statistically significant. I think neuroblastoma may be the last disease where we keep confirming that the more is better. Most of the time I said less is more, but here it seems like more is more. So we are now doing basically standard of care 2 transplants for neuroblastoma, high-risk neuroblastoma patients. Hodgkin's disease is an interesting disease historically, and if you remember in adult, when I showed adult data, a lot of transplants are done for lymphomas. So Hodgkin's disease can be treated with autologous transplant. If that fails, you can still salvage them with allogeneic transplant. There's a very strong graft versus leukemia or graft versus lymphoma effect in Hodgkin's disease. However, Hodgkin's disease field is changing. There are a lot of new drugs. I did remove the nice slides because I had too many slides showing survival with auto and allo transplant. Auto transplant probably has 60 to 70% survival. And then if they relapse, allo can salvage another 40-50% of patients who get allo transplant. But there are some very promising treatments such as anti-CD30 monoclonal antibody, also known as brentuximab, with very good survival rates. That one is usually used to get patients to auto-transplant consolidate. And then nivolumab, which is PD-1 inhibitor with excellent overall survival, overall responses and complete responses rates. Those drugs are still kind of used as transient drugs, antibodies and drugs used to reduce the amount of disease and get patients to transplant. The studies of skipping transplant have not completely been done, although again, these are very promising drugs. Oh, I'm sorry, I did leave those slides in. So this is survival after autologous transplant for Hodgkin's disease. Obviously, it's better if they are sensitive to chemotherapy. And this is for allogeneic transplant, saying you can still salvage a lot of patients who come to transplant. The downside of transplant is we just see the outcomes of those patients who come to transplant. We don't know what happened to all those, who might have relapsed after auto-transplant, never made it to allo-transplant. Some other pediatric solid tumors treated with autologous transplant are brain tumors. So basically, newly diagnosed infant intracranial primitive neuroectodermal tumors. Any infant, or infant, when we say infant, we mean anyone less than 3 years of age historically, any young pediatric patient with a highly malignant intracranial tumor such as rhabdoid, teratoid tumor, or PNET, or medulloblastoma, can be treated with high-dose chemotherapy and stem cell rescue instead of craniospinal radiation, which would have been a historically standard of care for those patients. Then we also transplant recurrent germ cell tumors, intra and extracranial, Ewing sarcoma, and desmoplastic small round cell tumors. A few words about complications. So basically, for allogeneic transplant, particularly non-malignancies, engraftment failure is a risk. Then there is obviously toxicity to very high dose chemo and radiation therapy that we provide, infections while the immunity is low, and then latent effects. Infertility is the major one, but then secondary malignancy, growth delay, hormonal deficits. And then the main still relapse in malignancies is complication or reason for failure in malignancies is relapse. Relapse can happen after transplant. It's always important to stress this out. The rates of relapse vary from 15 to 35–40%. These are just some causes of death in HLA-matched sibling category. As you can see, the primary disease is the big one in blue. I'm not sure why this other is so big. Infections are also the one of the main risks as well. Other is big in both groups. In unrelated donor transplant, again, primary disease is typically the main reason for death, particularly later on after transplant. So in summary, ALL and AML are the most common indications for pediatric allogeneic transplant. Neuroblastoma and PNET are the most common indications for pediatric autologous transplant. Allogeneic transplants may be linked to lifelong complications, and indications change over time, and each patient should be carefully assessed for risk and benefits of this procedure. Sorry that I did not leave too much right on them. At least we ended up